All right, I'm going to trim the messy bit from the beginning of this recording and get started. So, welcome everyone to our second CHAP public seminar for 2021. Thank you very much for joining us. So, for today's session, we're talking about demystifying medications for people with cardiovascular conditions. And we have two experts here with us today, and I will get them to introduce themselves, but I will tell you that we have Greg Roberts and we have Lemlem Gebremichael, both of whom are experts in the area of medication for cardiovascular disease patients. So, Greg, do you want to quickly introduce yourself?
My name's Greg. I've worked through the public health system in South Australia for a long time, and my passion throughout several decades has been medication safety, and largely across cardiovascular and anticoag, but across quite a broad range. Yeah, and Lemlem?
My name is Lemlem Gebremichael. I'm postdoctoral research fellow in the College of Nursing and Health Sciences. And I am interested in medication adherence and also evidence-based pharmacotherapy and overall quality of medication.
Thank you very much. So for this session, we have got a list of questions that come from consumers, from patients, and some that have come from clinicians, and some that I made up myself as common issues that come up online. So for today's session, what we're going to do is run it a little bit like a panel, and I will pose my questions to our experts and they'll give us their best answers. Feel free to pop in at any time if you do have any questions, and I'll make sure that we come back to the online audience and the in the room audience to ask if anyone wants to contribute. So let's get started. So my first lot of questions are around the discharge experience. So, Greg, I was given a lot of medications at discharge and I'm not clear what each of them are for. I was so overwhelmed with information, I could barely remember the conversation that I had with the doctor. What advice do you have for patients who have recently left hospital?
As a pharmacist, I recognise that as a patient, you're in an environment which is totally foreign to yourself. You're not wrong. Your thought processes aren't on top of their game. You may not have a medical background. You can't have a context of entirely what's happened. And to absorb all of this information in one big, it's just literally impossible. And one of the best pieces of information I've ever heard was that when people are a little bit disoriented and trying to communicate information, at best they'll remember 3 salient points when you're trying to communicate. So I always try and prioritise the 3 key bits of information that they need at discharge, but acknowledge the fact that they may or may not remember all of those, and they probably won't remember anything else you tell them. So you need clear written information pitched at precisely their level. So you might have a patient who's had a nursing background, you might have someone who's 80 years old and left school at 15 years old to work on the farm. So you need to understand exactly what level you're pitching at. And I think the written information is critical. That should happen at discharge in the hospital. If you had some complex medication charges, it certainly happens through all of cardiology at Flinders Medical Centre. We have an excellent discharge medication list generator just called Medication Profiler. So it's gone on the cloud now. And it is an absolutely fantastic part of the discharge process that we do for the cardiology patients. And it is just an essential piece of material information for the patient at discharge. It really does explain what the medication's new, if it's needs to be stopped or started or the dose changed, and the GP also benefits from that as well.
Yeah, so it's more than just their hospital. There's their allied health professionals outside of hospital to support.
Yes, and we'll often fax a copy to their community pharmacy, particularly if there's a Webster pack with some dosing aids involved. Or especially if there's instructions to restart aspirin or restart something else at a certain date. We try and communicate with the healthcare providers outside of the hospital, and we still don't do the discharge transition process that well, particularly we do it okay for the patient. The community pharmacists getting better, and the GPs get the discharge letter with the medication list on it. But that's written by the junior doctors, and it's well known, published in the medical literature, that can be inaccurate. So there can be discrepancies and confusion. So medication profile, the online version, is really picking up some steam now. We use it for all of our complex patients where they've got new medications. That's particularly the cardiology patients. That's been a big step forward in the last few years in South Australia.
Yeah. So if you had a patient that was going through discharge, who do you think would be the best person to answer their questions around medication?
That's a really good question. And most of the patients know who to ask, but like we did in the workshops, what I recommend is that they go to their new pharmacy because they don't need any appointment or any time to set for that, so they can go to their pharmacy and ask all the questions they need, and they get clear information about medications because they have experts in the medication area. And also they can ask their GP when they have appointment, or they can make appointment with their GP and the cardiologist whenever they are contacting for, and get more clear information. And further to that, they can also go to government websites or condition-specific websites that are legitimate or reliable resources for medication and right information for medications.
I'm going to come back to that online information, but just for the discharge experience, what is the one piece, the most important bit of advice you would give to a patient being discharged from hospital about their medication?
I think it would be to ensure that they don't hesitate to contact either someone back at the hospital, and when we give the medication profile, we'll have a contact number for them, or contact their community pharmacy if they have any questions at all about any of it. Community pharmacy has really stepped up in the last 5 or 10 years, as we start to improve that transition communication process. And most of the guys in community pharmacy now are really quite keen to understand what's going on. And we have the pharmacists embedded in GP practices now. And I spoke to a colleague, and she said, look, it's great if we get a discharge summary from the hospital, so that's fantastic. If we get one like the medication profile and it actually tells them the changes, that's fantastic. If we get one that tells them why they made the changes and what the plan is, she said, that is just like gold. She said, that is just brilliant. So we're starting to get better. Community pharmacy and PSA, the Pharmaceutical Society, are really starting to sort of step up and fill that void now. And so I think things will be quite bright, and that we will only see improvements from here on.
Yes, I'm going to come back to that too, about from a clinician's perspective, what sort of information around medications they need to be reporting. And so for Lemlem, what are the most important questions a patient might want to ask their doctor about any new medications they get?
I think they need to ask everything.
Yeah.
Regarding their medication, what the medication is, what is prescribed for, what adverse effects they can expect, although all the adverse effects may not be visible in that patient. It's good to know so that when they come, they will remember all that because of that medication, and they will know how, what next. And also they need to ask about their diets, drug interactions, any medication they can buy out of the counter in the pharmacy or herbal medicines. They should let their GP know what all this information is and how they can be affected by the drug interaction or food interaction and herbal medicine and the medication interactions.
Yeah. So no question is a bad question.
No.
And if you think it might be relevant, ask it.
Just ask. If you are not sure, just ask.
And I always say to my patients, I try and empower the patient. So look, these medications going into your body, you need to understand absolutely as much as you can about it. So we've got the stuff we're telling you here, but I would go and do more research and ask questions to the community pharmacist or GP. It's your body. You need to know exactly what's going on with the stuff that you're taking.
Yes, that's very good advice. And do you want to
Yeah,
expand?
and also They just need to know why they affect the medications. Maybe if they don't know, like we were just going in the workshop. If the patients don't know why they are taking the medication, it's probably high the risk that they will start taking it. So they should understand what the medications do, how they can improve their life, and what will happen if they don't take these medications.
I will deviate from my planned questions to ask one question, because you mentioned workshops a couple of times. Do you just want to quickly fill in the audience the workshops you're referring to?
In the CHAP project, we are conducting a workshop in the regional South Australia, and we are asking the consumers what information they need to know about their medication, physical activity maybe after rehab or during rehab. And all the information they're giving us is when they are discharged, like Greg said, they are overwhelmed with all the information they get from taking nothing to taking kinds of medications at the time. And they don't even understand what the medications are for, but they are told. So what they say is they take the description of the medications that are written and then go home and then try to sort out what the medication is, how it should be taken, and if they have any question to ask, they just ask further information for the GP or the pharmacy.
Yeah, okay. So what's been really clear and what both of you said is that seek more information, ask questions, and your GP, your cardiologist, your pharmacist are all good people to ask. You mentioned just quickly before about online resources, and you mentioned government websites. Can you give us any suggestions for what might be the government websites or websites to avoid?
I would say websites to look at, government websites, any website that is with
gov.au.
Yeah, that AU or any US or any UK websites that are gov, there are websites that they can rely on and get the right information. And I can also have the nps.gov.au, which has all the information you need, like CMIs or the product information or consumers engagement or medication information they need, what adverse effects they expect, all the brand names of the medication they are taking, and all the precautions they need to take, all that is in there. And additionally, I also found the app, the nationwide app. It's very useful and handy. It's government funded and it's free, so you can download it in your phone and you can get all the information like about what medications you are taking, the conditions you have, any adverse effects or allergies, contraindications, or you can also get the personal contact details of your health professionals. It's very useful. You can call them anytime you want or anytime that you are listed for.
So that was medication-wise?
Medication-wise, yeah.
Fantastic. Check it out.
Check it out, and you'll be amazed with the information you get. You can also set alerts on it to remind when to take your medications or when you need to refill your medications, all that. And you can also create lots of accounts in your one app for different or families.
Also, maybe you have your partners.
Yeah. And they will give you specific information about all the conditions. You don't have to remember what medication you are taking or what conditions you have. This will be all there, and you take it to your appointment or to your pharmacy and what will be going with you.
All right, so yeah, I have a question that I found from a consumer online, and they're talking about having been prescribed.
If you want anything else,
Go to another job. That was all for me today. And I'm going to talk to Lee.
Page that said that people shouldn't drive while taking that drug. Their GP
We're
hasn't
almost
said
good
that
to go on that one.
well, what she should find, I just made a few minor.
Yeah,
She's had a
cool.
little bit of work,
You're done.
and I think.
Thanks so
I've
much.
just got to get my last name.
You do.
done.
And then we'll talk about your job. Yeah, we'll
Next week. I'll
yeah.
go around completely.
Yeah,
There's a
you're
lot
not
of
there.
information out there, but it
Then
needs
we'll
to be
talk
taken
about
into context.
MRIs.
No, there is really
Yeah,
no reason
I know.
you shouldn't drive if you're on amphetamine.
I'm really sorry to interrupt. Someone's not on mute and I'm getting 3 or 4
Oh,
different
some feedback.
conversations in the
Yes,
background.
Can I just check that they are on mute?
Yeah.
Fantastic, thanks guys. Sorry, can you please continue, Greg?
So you will get recommendations. One of the things we discussed is if you look even on some of the .gov websites, the mandated ones, there's this massive list of potential side effects, and a lot of those really are just brought over from large studies where the active drug has been compared to a non-active drug. But even the people with no active drug will have a whole range of side effects. So they all get reported. So runny noses and a bit of nausea, loose bowel action and all this sort of stuff. And if someone got a bit drowsy while they were in a trial which involved nifedipine, then that gets listed in there. So the manufacturers, when they do the guidelines, they have to be very, very medico-legally safe. So they will put everything that's in there. Every time that someone has sneezed while they were even in the vicinity of nifedipine, that will go into the website. So when you see consumer information, it's incredibly important to have a perspective on it. So you would get that perspective from your community pharmacy or your GP. The community pharmacy is a lot more accessible, or ring up the hospital or drug information lines. But if you don't have a medical background, it's really incredibly important to get a perspective on this massive list of side effects that come from every drug. And if we stopped everyone on nifedipine from driving, we'd have to pull about 10,000 people off the road in South Australia alone.
People would not take it.
So it's just a little bit of a crazy recommendation, one which was sort of medico-legally driven, I suspect.
So we've talked a little bit about where people might get information from. This sort of stems on from that. Questions around how medications actually work. So this is one that has come up online as well. So my kidney function has recently been found to be impaired as a result of my diuretic medications that I was prescribed. They've since halved my dose, but I now need to monitor my kidney and blood tests. I don't understand how this happened. What are the diuretics doing that caused this damage, and could this damage have been avoided? Who wants to field that one?
I'm happy to talk a bit about it. Particularly with heart failure, one of the issues is your heart doesn't quite pump enough blood through your kidneys, so you don't. Sometimes you get a little bit of fluid buildup. Your kidneys get rid of the fluid in your body, and you get a little bit of excess. And we give the drug called furosemide to get rid of the extra fluid. But if you give a little bit too much furosemide, then you get rid of too much fluid, and your body gets a little bit dehydrated, and that switches your kidneys off. So it is a bit of a balance between the kidney function and the dose of furosemide. With heart failure, it's not uncommon, if the patient feels comfortable with it, to say to the patient, look, you're on 40 milligrams of furosemide. If your ankles get puffy, if you weigh yourself regularly and you put on more than 2 kilograms, perhaps 2 or 3 days in a row, you notice that you're more than 2 or 3 kilos over normal, then take an extra dose of furosemide for maybe 3 days, and just bring up your GP and have a chat. What that does, we find, is it'll often stop people from being admitted to hospital, because once you get about 4 or 5 kilograms extra,
you would really notice an extra 4 or 5 kilograms of water.
Well, yeah, people get puffy ankles, and it happens slowly. So sometimes they think, oh, okay, it's not too
just
bad.
gaining weight, or
We had one lady come in years ago at repat, and she had an extra 21 kilos of fluid on her, and she had the extra fluid up to here, up to her hips. You could put your finger in and see that there was too much fluid there. Problem is, once you've got an extra 4 or 5 litres, to get rid of that, you need to be in a hospital to take it off. Otherwise, if you're reducing the fluid in your body, there's more of a chance of having the kidney failure,
issues,
which the question you described. So, yeah, with the good patients, we can empower the patient. It's not uncommon to see the patient with heart failure monitor their own weight or ankles. And I just commonly get patients coming in, you're on the furosemide, do you use it much? I only use it once a month for 3 days at a time. My ankles get a bit puffy. My doc says, Yep, give yourself 3 doses and then it's better. So it's a common practice now.
Yeah, I think you already mentioned it. So it's the balance that they should keep with the dose amount of food they need to remove from the body, reduce the amount of food accumulation and the kidney function. So when they are too much dehydrated, it will affect the kidney itself or the medication itself. Other medications probably they are taking, and that also could affect kidney function. So it's just to keep the balance between the risk and benefit.
And to put that in perspective, if you got dehydrated from some other cause, the same thing would happen with kidneys would probably switch off. So it's not just the furosemide that does it. It's not just drugs that do it.
So that discussion about empowering patients, I think that's very important. And do you think patients can be adequately educated about their risk factors and that they can identify them and let their GP know if there's a problem occurring?
Absolutely. You just need to assess the medical literacy of the patient. So some patients can do it all. They've got a good background. They may not have a medical, nursing or whatever background, but they just apparently understand and take on the information. And for other people, it's a little bit more difficult. So you have to pick your targets and understand at what level you're pitching it at. Because you don't want to have people offering furosemide doses if they don't understand what they're doing, of course.
Yeah.
So it's a real art to understanding what you're working with.
And I suppose it's up to the GP to build that relationship and to be aware of what their patient might feel comfortable taking on board. So I have a lot of questions about administration, so I won't ask all of them. So if you do have any additional questions, please feel free to pop up. So most of my medications are in pill form, but I really struggle to swallow them all. Is it a problem if I crush my pills up and mix them with water to get them down? What do you think, Lemlem?
Good question, because lots of patients might be doing that. But from medication perspective, every medication is made either in tablet, capsule, or any form for a purpose. So if you crush a medication which is in capsule, what it was supposed to be capsule and go to specific area of your body to work properly where it should be. If you crush it, it may cause lots of problems, either it can cause overdose, or it can also, when you mix it or crush it somewhere, you are reducing the dose too, and you can also get the interaction with the mixing of the medications. And besides that, you can also get adverse effects, cumulative adverse effects, or like for the aspirin, you have the coated aspirin, that you coat the aspirin because it's private irritation of the GI. But if you crush that and swallow it or coating on adverse effects that you are not supposed to get. So unless you get advice from your GP or your pharmacist that you can do the mixing or crushing, please don't do that and put them as you are supposed to take or as it's prescribed.
Okay, so definitely check in advance. But are there options if you're not good at swallowing pills, or if the medication is being delivered in a way that doesn't really work for you? Are there alternatives? Can you switch your medications out?
That depends very much on the medication. So some medications we've got options such as the nitrates, you can wear a patch rather than take the tablets. Generally, the tablets or some sort of oral formulation is the only thing we have. And whether they can be crushed, check first. Some can be crushed, some can't, particularly the tablets that are slow release. We have a lot of slow release medications nowadays, and they generally cannot be crushed at all. Otherwise, you destroy the slow release characteristic. But many can, and pharmacists have an excellent resource. It's called Don't Rush to Crush, part of the MINS guideline, and that is just excellent. So every nurse and every pharmacist races to that. I use a lot of it on the ward because one of the surgery wards I'm on do a lot of throat surgery, and they can't take anything several days at least, sometimes a week. So we have to look at, can it be given subcutaneously, venously, by a patch, by a spray, sublingually. So we sort of explore all the options.
So it's worth asking. Definitely worth asking before you crush, but it might also be worth asking if there's an alternative.
You just have to ask every time.
Now, this one I know is close to your heart, Lemlem, about medication adherence. I struggle to remember to take my pills on time every day. Can you suggest some tips or strategies to help me remember?
I think it's like remembering how to go or where to go to work. If you are starting to live with medications for a long time, keep going, you need to take them every day. So you have to integrate it into your daily routine in different ways. Some people just remember it as taking their breakfast before breakfast or after breakfast, and like that, put them into your routine. Or you can also use your mobile phone as an alert or mobile reminders, or you can also use handy apps that are pharmacy oriented. Like we have found out
The
in
medicine-wise,
workshops, medicine-wise,
Yeah.
lots of apps that the pharmacists can provide where you fill your medication. You can use those apps and then try to take them in time for you to live good quality or better than not taking medication every night.
Okay, so I think I know the answer to this one already, but a question that does come up: if I unexpectedly run out of medication, is it a problem if I miss just a day or two?
That's a little bit of a loaded question because it would depend very much on the medication. So something like aspirin, the effective aspirin lasts probably 1 week. You can miss 2 or 3 doses, and it really won't. And it's aspirin's a long-term game, so it's really you take your aspirin so you don't get a stroke in the next 5 or 10 years, or you don't get a cardiac issue. It's the same with the statins. But there are some medications where it is very, very important really not to miss a dose. You know, this antibiotics is an obvious one. You've got a course of antibiotics, but blood pressure tablets, sort of in between. Wouldn't want to miss your blood pressure tablet, but if you did, it's not going to be the end of the world because it's
You
usually
won't keel over in a night.
you won't fall over in one night. Your blood pressure might go up a little bit, but again, it's a longer term game. You're trying to prevent a stroke from constantly high blood pressure that might occur in 5 years or 10 years. I think the other ones, the stuff like the nitrates that might be an issue because if you don't take it, you'll probably get some chest pain. So you've got a big incentive to not forget that one. Then you can probably think of some others.
I think you already mentioned that. So yeah, it depends on the medication that I'm taking and the efficacy immediately, like you said, for nitrates, and that would be my advice. We have patients who are traveling on their pocket with their nitrates, so they will take it whenever they need. And there are medications that you don't have to worry too much because you miss 1 or 2 doses. Yeah.
The critical one, which is not a cardiac one, but which really just sprung to mind, is insulin. If you're diabetic,
Oh yeah.
taking insulin, that is absolutely incredibly important. That is the top of the pile.
Yeah, you get that one right. Oral nitrates has come up. So somebody asked about oral nitrates for chronic angina. They're taking it to get relief for up to 8 hours is what they've been advised, that the oral nitrates will last that long. But they're actually finding that the pain relief is not lasting up to 8 hours and that they want to take more sooner than that. Should they be talking to their GP about increasing their dose?
Absolutely. Well, they should talk to their GP, but really it's about reviewing their medication. So it's clear that their medication regimen is not appropriate for their symptoms. It's not managing the symptoms well. And that might be that the patient is taking too much nitrate. So the reason we only take nitrate once a day and it only works for 8 or 12 hours is we take it constantly. Within about 3 days, we get it's a glutathione depletion. So the nitrate stops working after about 3 days because it exhausts the supply that it needs, the substrate that it needs to work. So there's that issue. They might be just dosing it wrong, but also they just might need new medications. It may not be enough for them. They may need new ischemic heart disease medications to stop their angina.
Yeah.
If you've got whatever the case, whatever the cause is, if you're on a medication regimen, you've got any breakthrough symptoms, you need to go and see a doctor straight away. There is a small chance you're having a myocardial infarction, a heart attack. So that's one where you would get in and see someone quite quickly. If all of a sudden you started to get angina when you didn't have it before.
Anything you want to add to that, Lemlem?
That's awesome.
All right, so I want to move on to the next topic, which is about living with medications long term. So we're thinking about this is something that you might have to live with for the rest of your life, and so how to incorporate medications effectively into your life without ruining your usual routine. So here's a very broad question that crops up quite a bit online. Can you take medications? Can you take vitamins while on heart medication? Is that it depends?
It depends. Yeah. It depends. So yeah, you might take them as needed, but you need to be in contact or in what do you call it? In communication. You have to be communicating with the GP or the pharmacist that you need this vitamin or minerals, and then you have to see if that medication can change the interaction or the effect of the medication that you are already taking. And yeah, you need to communicate and see if it's useful for you and it doesn't have any bad effect on your body because of the medications that you are already on.
I think that's really important to say, that they should both be useful and also not causing problems. Just if they're not causing problems, but they also don't worry. That's something that you want to consider as well. Another super broad question for living with medications. What advice would you have for people who are taking heart medications about incorporating them into their everyday life?
We did sort of talk about that. It's just a pattern. It's like anything. If you have a cup of tea in the morning, you have your medications, but most people will benefit from having simple dosing aids. You can fill them up yourself once a week, and it just what it means really for most people is that if you're running around in the morning, you're doing a whole lot of stuff, and you take your tablet, and you come back an hour later, you just think, oh, did I take it or not? You can go back to the dosing aid. If it's gone,
it's like one of those little trays.
just a little tray. It might be just as simple as Monday, one little square for each day of the week. If you go back there and it's empty, you know it's probably down here somewhere. So.
I do have a question for myself, because I don't actually know the answer to this. Does it matter what time of the day you take your medication, as long as you take it consistently, or does it really matter? Some need to be taken in the morning, some should be taken at night.
I think it depends. Like if you are taking the medication for your sleep.
Oh yeah, it doesn't make sense.
It doesn't make any sense. But for other long-term medications, as far as you are taking them consistently at the same time and at the same time of the day, I don't think it will matter.
The one that really stands out is probably frusemide. Some of you might remember the very first brand name for frusemide was Lasix, and it was a conglomeration of lasts 6 hours. So the diuretic effect lasts 6 hours. That's why we give it in the morning. But we always counsel the patients. Look, if you're going to the supermarket at 9 or 10 o'clock, if you've ever found a toilet at a supermarket, you've done better than I have.
Yeah.
You can hold off until 10 or 11 when you get back and take your Lasix then. But you don't want to take it just before you go to bed unless you want to get up every 2 hours. So that's an important one.
Yeah, so you don't want to be busting to go to the loo when you're out in public, but you can't put off taking it forever either. So there's a little bit of flexibility.
Yeah, and you don't want to get up at night. So as far as it's convenient for the patient, fix the time and be consistent with this.
Yeah. This one was quite a personal question that came in. So my pharmacist is very clear that I cannot combine nitrates with Viagra. So how can I manage my high blood pressure without ruining my sex life?
It sounds like a boy question, so I'll
Let boy.
Talk about, there are probably now 2 main tablets for erectile dysfunction. The well-known one is Viagra, or sildenafil, and there is a longer acting one, Silence or something. So The receptor that Viagra works on is very, very specific. The phosphodiesterase 5 type receptor. It's very specifically geographically located in the down nether regions, which is why it works, but also through the blood vessels. So the other action it does is actually dilate the blood vessels, which means your blood pressure goes down a bit. So if you're on medications which are lowering the blood pressure, normally antihypertensives, and you do take some Viagra, you get a double dose of blood pressure lowering. I think on average Viagra lowers your blood pressure about 5 mil per mercury per minute. So,
which doesn't sound like a lot, but if you're already
you've already got a slightly low blood pressure, then you put a fairly potent antihypertensive on top of it. There are cases where people have had big drops in blood pressure, but they've got faint and dizzy, and it's even precipitated cardiac event. So I think the general advice is that you normally need to wait 24 hours. If you want to take one, wait 24 hours before you take the next one. The nitrates will certainly wear off before that period of time. The Viagra will take about that long, but the new one, the Silex, will take about 48 hours.
okay. So this is definitely a discussion you need to have very clearly about what you're planning to use when you're planning to use these drugs.
You need to sit down with your GP and have a good chat about this, because you don't want to end up unconscious on the floor because of blood.
Yeah, that would really kill the sexy times.
That would be a
but this is sort of bringing us to the next topic about side effects, and we've sort of left this a little bit later on in this discussion because we didn't want to leave with the scary stuff, but it is definitely a topic that people have a lot of concerns about. So I actually have quite a few questions for this section, and we'll start with an easy one. So I recently started getting nosebleeds. Is this a side effect of my warfarin pills, and what can I do about it?
I will leave this. I can answer.
I work on a surgeon floor at Flinders Medical Centre, and all of the admissions for basically bleeding into the brain and bleeding into the gut are admitted there. It is generally related to warfarin and another group of blood thinners called the DOACs, which are probably used a lot more than warfarin now. And sometimes just aspirin will do it. And we would see 3 or 4 admissions a week for this. It is really very common. The warfarin one was more common because there are many side effects, drug interactions. There are in many ways that the potency of warfarin can be affected. And sometimes when it's affected in a manner that it makes it more potent, you will get a nosebleed. If you're really unlucky, you might have a bleed into the stomach. If you're very, very unlucky, you'll have a bleed into the brain, which is very dangerous.
So take the nosebleeds, honestly.
Take the nosebleeds. Having said that, there was one patient, and we try to get patients now to swap over to safe alternatives. So there are safer blood thinners than aspirin in that category. Aspirin has into blood a little bit, and so you're more likely to have a bleed because of that. But as well as that, there's a totally separate side effect. It has an erosive effect on the gut lining. So you've got to distinguish the fact that there's a little bit of a bleed because your blood's a bit thinner, but there's a higher risk of a gut problem because it's like there's a little bit of sandpaper rubbing against the inside of your stomach. So we can swap over to another one for that. And for the warfarin, in that more potent group of blood thinners, we can swap. Generally, we would recommend swapping to one called apixaban, which has got a much, much lower rate of tummy bleeds associated with it. On the nosebleed thing, just recently, a patient I was talking to, we were talking about the same issue. She'd had a bleed, and we were talking about swapping her to apixaban. And she had 2 previous admissions, 4 bleeds, nosebleeds, and 1 rectal bleed. But then talking to her, she said, I would have had at least another dozen times where I've had bad nosebleeds.
And not come in.
Okay, well, that's now starting to really impact on your lifestyle. And we need to think about medication changes. So it is the most common drug side effect by far that I see in the hospital. It is just streets ahead of whatever is next.
That would be why I had two questions on this, because there was another question asking about stomach bleeds and the drug that had caused it. So is there any way to make the bleed less likely?
Yes, there is. So instead of aspirin, if you had a bleed on aspirin, we would swap you to one of the other antiplatelets. If you had a bleed on warfarin, we'd swap you to one of the other more potent, drugs less likely to cause a tummy bleed. And there's much less likelihood of having a tummy bleed when you swap to these other ones. But there's also a protective agent we can use, proton pump inhibitors. So it's not common, it's common to see people who have been put on these things and they may have other risk factors going on, so the doctor will put them on proton pump inhibitors. The common one is Nexium or pantoprazole, and that will help decrease the likelihood of a tummy bleed. Not the other sorts of bleeds, but it will decrease the likelihood of a tummy bleed, probably in the order of 30–40%.
Okay, that's pretty significant.
And it's also good to consider drug interactions, like physicians could have been taking other over-the-counter medications that can also improve bleeding, like the NSAIDs. So it's good to aware the patients that if they are taking other medications that are prescription, they need to be aware there could be an interaction that can occur.
Yeah, so that might be another alternative. Going with those.
It's an excellent point. The non-steroidal anti-inflammatory agents, and this is, you know it as Brufen or Voltaren, and Nurofen is another one. They're available on the supermarket shelf with a whole myriad of brand names. And about once a month, we would have a patient admitted to the hospital with a tummy bleed. And you have a close talk and say, oh, I had a lot of pain in the last 2 or 3 weeks, and so I just swallowed a whole lot of Nurofen from the supermarket shelf. They weren't on anything else, but 2 or 3 or 4 weeks of Nurofen is enough to give them a perforated ulcer, give them a tummy bleed.
And there is that sense that the medication you can buy at the supermarket is harmless, that you can't take too much.
If you're already on a blood thinner, like aspirin or warfarin, then, or you're sitting on a stick of dynamite.
Not only that, they don't even also take the right dose. When they are taking over the counter, they think that it's really safe, and they take whatever.
Take 4, take 6. Yeah.
And then that causes a problem.
I thought this one was particularly interesting because I've heard this side effect come up. Somebody talking about vivid dreams and insomnia since taking beta blockers. Is that a side effect of beta blockers, or do you think it might be caused by something else?
I had a case of exactly this at REPAP years ago. The patient was commenced on one beta blocker called metoprolol. Now, there are some subtle differences between the beta blockers. Some of them are very fat soluble and some are very water soluble. Now, for the vivid dreams to occur, it has to the drug has to sneak in and start drinking with the brain. Now, the brain has almost got its own little suitcase in the body. There's a barrier there. And for the drug to go from the general circulation across into where the brain lives, needs certain properties. It can't be too big a molecule, otherwise it just won't fit. But it needs to be a little bit fat soluble to be able to sneak across. So this patient started on a fat soluble beta blocker called metoprolol and was just complaining of these weird vivid dreams. He was freaking him out. And we swapped. I told the team to swap to atenolol, which is a water soluble one, and no problem. Just stopped straight away. So yes, it is a side effect, but we can, within that group, we can actually change it up so you're less likely to have that problem, because they are extremely one of the first line drugs for ischemic heart disease, for heart attacks, angina. That's the go-to drug.
Yeah. But for some people, do you know what proportion of people might have that side effect? Is it rare?
Oh, it's rare, but you would have to specifically ask the patient, because they often won't relate it to
make that connection.
Medication.
Yeah. It seems a little odd, right? Yeah, and now you've explained it, it does make sense.
They might be just embarrassed about it.
So I'll ask one more question from this section about beta blockers again. When I go for a walk, I seem to be getting puffed up easier. So a bit of fluid retention. Will my body get used to the drugs, or am I going to feel like this forever?
I think it's related with the mechanism of action of the drug. They have the drugs that are reducing the heart rate, and when you are doing exercise, your body is needing more oxygen and food. So that will cause you more tired and exhausted. So yeah, that's why you need to moderate the drug and with the activity that you do every day.
Beta blockers, as Lemlem said, moderate your heart rate, and probably they're very good at capping the ceiling. So what it does is take your maximum heart rate back a little bit. And so people will typically describe an exercise intolerance. They can't, when they're exercising at higher levels, they'll get puffed a little bit easier.
Yeah.
There's one other possible aspect of that is when a patient is newly prescribed beta blockers for heart failure, you have to increment it slowly. So the beta blocker, one of the issues with heart failure is one of your nervous systems, one of your subconscious nervous systems goes into overdrive, and we have to quieten it down, which is what the beta blockers do. So 20 years ago, people used to give beta blockers to heart failure, but they used to start them on a big dose, and the body couldn't handle it, and would actually kill patients. So 20 or 30 years ago, if you got told if you suggested prescribing a beta blocker for heart failure, you would have got kicked out of medical school or pharmacy school. Then we realised actually the body needs time to adjust. So when we start newly on the beta blockers, it's often a period of 4 months if we work up to a maximum dose, depending on how the patient is tolerating it. And it's possible that when you do start a beta blocker for heart failure, it may take a few weeks for your body to then adjust to that level of beta blocker. And then the doctor might increase it again. So there might be this to and fro where your body's adjusting. You may feel a little bit tighter, and then the body adjusts. And by the time you get to the end of it, you'll feel a lot better.
It's a bit rough that at the same time they're being encouraged to be more physically active for cardiac rehab is the same time that they're starting to feel more fatigued as a result of their medication.
Yeah, I think once they don't make that medication.
Yeah, you have to have the medication, but you should also be doing the physical activity. So yeah, a bit of balancing act.
It's a significant light at the end of that tunnel.
Yep. And just one more question for this section. Since taking Ramipril, I've had an annoying cough that's keeping me up all night. I'm planning to stop taking them. What could happen if I do?
Oh, well, that's what I said at the beginning. You have to communicate with your GP that you have this adverse effect. And obviously, these acid inhibitors, including, they have the adverse effect of causing dry cough. So that's an adverse effect of the medication. And the patients may be aware of that when they are getting this medication. So there is a solution for that when you communicate. So they will switch to other drugs like the ARBs, which have no adverse effect like that. So it's good communication to get changed to other medications, no adverse effect like that. That's stopping it before.
Yes, don't just go off cold turkey.
Yeah.
The GP or the pharmacist knows that this is a new drug for you, that they the main side effect you would warn them about. It's probably a 5 or 10% incidence. And the patient should be alerted to that as they start taking them.
Now, for the last section, to finish it off, I have some clinician questions, but I just thought I would open it up to see if anyone had any questions of their own that they wanted to put in. Now is your chance. Otherwise, I've got a couple more questions from the clinicians. No worries, I'm going to continue. So let me see if I can pronounce this correctly. So we just were talking about beta blockers. So I'll start with this one. So I've noticed some patients without apparent contraindications are not started on a beta blocker after a myocardial infarct. Is a beta blocker still regarded as a routine medication post-infarct?
I think it's guideline recommended. They should be on beta blockers. And they reduce mortality and hospital admission rate, which is confirmed, especially for the after post myocardial infarction discharge for 2 years. They should be on these medications. Yeah.
But is there still a bit of hesitance, do you think, amongst clinicians to prescribe beta blockers because of what you mentioned about 30 years ago it was killing people?
There might be hesitancy if the patient has a little bit of airways disease. I think if it's what we call chronic obstructive airways disease, the one related to smoking, I think it's clear that you still benefit by having a beta blocker. The worry is that the beta blocker might constrict the airways a bit, but the beta blockers we use are specific, more specific for the heart, and they don't really affect the airways. If the person had genuine asthma, where their airways do quite frequently constrict and dilate, you'd monitor it and just make sure they're okay. But you can see maybe there's a little bit of confusion with some prescribers about whether to, in those circumstances, whether to prescribe or not. But for myocardial infarction, for heart attacks, using a beta blocker after a heart attack is the thing to do.
Yeah, and as you said, it's not with no contraindications. It's just they don't want to prescribe the blockers, which is not fair.
Yes. So the guidelines say beta blockers. Yeah. What determines the choice of dual antiplatelet therapy? So, for example, here we go. Clopidogrel or
Clopidogrel or
Thank you. Combined with aspirin after coronary stenting. You know, I did actually look up the phonetic pronunciation of these, but not those two.
Right, that's a little bit of a minefield at the moment. The goalposts around what to prescribe and for how long are varying a bit. There's new information coming out all the time. Just as a background perspective, aspirin was the first antiplatelet mild blood thinner that we had. The next one that came along was clopidogrel, and we used that, and that was good because it didn't have the tummy side effects and it was a little bit more potent. We used that for 10 years before we realised it actually doesn't work in about 10 to 25% of the population due to it needs to be converted through one of the liver enzymes to be active. And everyone taught me all about it, and then 10 years later, whoops, it's actually not working in 20 or 30% of people. And then ticagrelor was the third one, which is probably even a little bit more potent again, but has to be given twice a day. And to put that in clinical perspective, if someone comes in for surgery, most of the surgeons, when they're doing even major cardiac surgery, they'll say, okay, keep the aspirin going, but stop the other ones. And you talk to the surgeons, they say, oh, they don't want to operate on someone that's still on clopidogrel because the blood is just too thin. So there is a little bit of a potency order within that class. And then think about warfarin and pixaban and those other ones. They're a different action, and they're the blood thinning potency of aspirin and clopidogrel is here. And the other ones are up here somewhere. It's 3 or 4 times more potent. But we need the aspirin and the clopidogrel and ticagrelor for the coronary arteries because it's a different form of clotting, which only the antiplatelet drugs affect, more so than the other blood thinners, which have a different mechanism. So it's very specific for platelet-driven clots in the heart. Now, of course, initially we only used aspirin because that's all we had. Then probably 15, 20 years ago, clopidogrel came out and started realising if we combine them, it's a much better outcome. And then we looked again, it's a better outcome, but we're causing more people to bleed. And then ticagrelor came along, and then we're saying, all right, we should stay on aspirin, but then after 3 months, or 6 months, or 12 months, or 18 months, we stop the second one, or maybe we can stop aspirin. So now people, there are all these combinations of what we're doing after, and some of them look okay, and some of them don't. Some of them look okay in one group of patients and not others. So it is just.
So the question of what determines the choice is a whole lot of things.
So your doctor may sort of decide, okay, and it depends on the sort of stent and how serious the operation was. So they might think 2 antiplatelets for 3 months is fine. and then just go back to one. Some might think we actually just, 4 stents and all this other stuff went on. So maybe you want 12 months before we think about taking it off. And other people will just leave you on 2. Look, it really does depend on the clinical circumstance, and it will depend on the doctor and their approach to it. But the information is changing rapidly around that, but it's still not quite clear what the best timing is. So it's certainly having 2 immediately after is best. But which one to stop and how long before we go down to 1 is very much still a question that needs to be answered.
Those are individual circumstances.
So the doctor will determine, depending on your set of circumstances, so your clinical circumstances.
Now we do have a question from the audience. Eleni, do you want to turn your mic on so you can ask?
Yes, thank you. Thank you for the fantastic debate and presentation. We know that many patients with cardiovascular disease, they are usually on a large number of medications, and sometimes, and I would say frequently, they experience gastric intolerance. And do you have any practical tips on how to deal with this?
It's a medium.
Easy question. Easy question.
Some of it will be medication related, but it might be worthwhile exploring their dietary habits first before you start exploring medications too much. And it might be that their dietary habits lead to inconsistencies with whether they feel nauseous or not. That's a minor thing. Then when you explore the medications, usually there will be 1 or 2 culprits that stand out as causing problems. Something like metformin for diabetes, people just don't realise that it's really quite common. The aspirin sometimes can cause that tummy irritation. And so normally you would build up a list of suspects, and it might be a long list of medications, but you would actually determine which are the ones most likely to cause it. Has it become a serious lifestyle issue for the patient? And if it has, then the GP may look at those medications and from the most likely culprits determine, can there be a dose reduction? Sometimes that will take away the issue. Or is it due to a drug that they just can't be without and they really should stay on that drug? Or is there an alternative class? So sometimes, like in the previous example with the ACE inhibitors, we can go to the angiotensin receptor blockers, the ARBs, which are sort of cousins of the ACE inhibitors. Same action, but sometimes different side effect profiles. So there's a whole lot of nuanced tinkering you can do around that. And it would depend very much on the patient, their medication list, their lifestyle habits, perhaps their comorbidities. So, someone with diverticulitis is one of the background comorbidities. Well, you probably bang your head against a brick wall tinkering with the medication because their diverticulitis is going to ensure that they've got irregular bowel habits anyway. So a loaded question, a good one. That you would need to dissect all that stuff about your patient, their comorbidities, their lifestyle, their diet, and then their medications, and try and prioritise from top to bottom which is the most likely culprit to be causing, and how much of an issue is it for the patient.
Yeah, okay, thank you.
But it is a relief to hear that it's not an open and shut, as in you're on these medications to keep you alive. There's nothing we can do. There's still some wiggle room for a lot of patients. Anything you wanted to add to that one, Lemlem?
I think it's been already.
Yeah, fantastic. Thank you very much. Now we are out of time, so we'll have to draw it there. I do have another question to ask later. But thank you very much for joining us, Greg. Thank you very much for joining us, Lemlem, and for answering our questions. And thank you very much to our audience. And this recording will go up on our CHAP webpage, so you can always pop back in and have a look. And for anyone who missed this session, here's an opportunity to hear it there. One last question. Go ahead.
Hi, my name's Julie. I'm the pharmacist on the Heart Foundation helpline, and this was a great presentation. I really was wanting to see was there other questions that the public's asking that I wasn't aware about. So it was a really good overview of what you guys are getting. They're all the same things that I'm getting too. So yeah, so that's really good to hear, and thank you both for your lovely explanations. I will say the microphone causes a lot of feedback. Just to let you know, I think because your room's very empty, that might be just as a little tip for the next one. But
definitely keep that in mind for our next session, because we do want to make more of these face-to-face, bring the people back.
Yeah.
So we'll investigate that more for our next session. So thank you everyone for joining us today, and we look forward to catching you at our next public seminar, which will be in 2022. Thanks very much. Bye. Microphones might cause more problems than myself.